Fellow Children's Hospital, Boston, and she's presenting on colitis predominant XIAP deficiency with clinical response to TNF-alpha inhibitor. Amy.
Thank you for inviting me today to talk about this interesting case. I'm going to review this patient's presentation of IBD predominant XIAP mutation, and then review a little bit the heterogeneity of XIAP mutations, and finally talk a little bit about TNF inhibition and its role in treating these patients. And I have no disclosures. So the patient was a male infant born in Puerto Rico to a 29-year-old healthy mother. Interestingly, at birth, he was diagnosed with high drops and required multiple red blood cell and platelet transfusions throughout the first month of life. The high drops was resistant to IVIG therapy and was thought to be non-immune. From that point on, he continued to require intermittent red blood cell and platelet transfusions throughout the first year of life, but it was not as profound as in the first month. At the same time, he gradually developed severe failure to thrive that became very evident by 10 months of age, and it was characterized by severe, persistent, not frankly bloody diarrhea, and persisted despite changes in formula and multiple other interventions by his healthcare providers. And here you can see his growth chart. In the lower left is the weight, and you can see he does okay until 3 months, still falling off, and then abruptly plateaus and starts to lose. That last point there is what he weighed and how tall he was when he came to see us in referral. At 17 months, he was only 3.9 kilos. When he arrived at our hospital, he was severely cachectic, as you might imagine. He had hepatosplenomegaly. And our primary team that was managing him did an extensive infectious and metabolic workup, but no disorders were identified. He had a GI evaluation that showed colitis, and I'll show you some pictures of that in a moment. And then, interestingly, in his bone marrow, he was normocellular, but had what the pathologist called possible inclusion bodies, and then had a similar finding in his peripheral smear. And finally, something I think that was a red herring that threw us a lot threw everyone off track is he was profoundly hypocholesterolemia, even when he was on parenteral intralipids. And here you can see some pictures of his colonoscopy. I'll just point out briefly some punched out lesions in the transverse colon, and some more hemorrhagic colitis further down. His infectious history was not that overwhelming. At 3 months, he had bronchiolitis, as so many children do, and at 13 months, he had an abscess at an infected IV site, so nothing too overwhelming as far as infection. Nonetheless, our primary team, in their thorough evaluation, did an immune evaluation. And you can see here that his immunoglobulin levels were all normal. Excuse me. They did pneumococcal and tetanus titers, and these were all quite robust. He had been fully immunized. But when they looked at his cell phenotypes, he was lymphopenic in the T cell subset, specifically the helper T cells. And he also had a almost absence of NK and B cells, which was really surprising to us at the time, given his very good antibody production. It was quite confusing. When we looked more closely at his T cell subsets, you can see here that his naive populations were restricted in both the CD4 and CD8 populations. And he seems to have a compensation in memory cell proliferation in the CD8, which is probably what made his CD8 cell total count normal. And then of note, he also had normal T regulatory cell counts, and we did send for FOXP3 in collaboration with our GI team, and the sequencing for that was normal. His mitogen and antigen stimulation testing was essentially normal. But despite not having a diagnosis, we had to do something for this child, so the team started him on TPN and intralipids, and then eventually decided to start steroid therapy, given his inflammation in the colon. But he didn't respond to either of these therapies, continued to have a lot of diarrhea, up to 15 stools per day, very watery in nature, and was still not growing very well. His metabolic derangements had corrected at least with the TPN. So the GI team decided to take a shot in the dark and start adalimumab, which is a TNF-alpha inhibitor. And at that point, his diarrhea decreased, and he was able to come off peripheral nutrition, started gaining weight, They stopped the steroids. After about 3 months and only a few weeks on the adalimumab, he was able to be discharged from the hospital. And he started gaining weight again. But I think the most striking feature was here was this child who came to us at 17 months, completely bedridden, totally cachectic. His developmental milestones were that of a neonate, couldn't lift his head off the bed, not verbalizing at all, to 1 month later, obviously with severe rehab, being able to sit up, verbalizing, so completely different child. And you can see how his growth takes off in the time that he was in the hospital from admission to discharge. So to summarize him, he had severe failure to thrive with chronic diarrhea, with chronic milder anemia and thrombocytopenia. He had inflammation in both his colon and his liver, and we did do liver biopsies, but I didn't show you those. And immune-wise, he had low CD4 cells with decreased naive CD4 and CD8 cells, but a good mitogen response, and then nearly absent B and NK cells, but good antibody production. And then he had this finding of hypocholesterolemia. So one of our fellows had gone to the ESID meeting in the fall and heard about a case of XIAP mutation causing just colitis and IBD-like phenotype. So running out of things to test him for, we checked for this, and sure enough, he had a XIAP mutation that caused a frame shift and then an immediate stop codon, which was consistent with XLP type 2. When we look at this patient compared to at least the French cohort of published XIAP mutations, you can see that the most predominant finding in most of these patients is HLH or HLH-like disease. And if you looked at what this patient had, he had cytopenias, splenomegaly, and hemorrhagic colitis, but was lacking the other typical features. To look a little more closely at the question of HLH, since this is such a predominant feature in most patients with XIAP mutation, he actually does fit quite a few of the criteria, although he never had fever at any course in his disease, and it was never really a fulminant presentation. But he has the splenomegaly, the cytopenias, and the ferritin increase. It's hard to say whether his NK cell activity was good because his NK cell levels were so low to begin with. Looking at XIAP, the gene, there's 3 baculovirus inhibitor of apoptosis repeat domains, or BER domains, which are known to be involved both in preventing apoptosis and in some ways in inflammation, and then a ring domain. And if you look at the 3 most widely reported cohorts out of France, Japan, and US and Cincinnati, and then match the phenotype, so HLH phenotype, HLH plus IBD, and then IBD alone, there doesn't seem to be any immediately obvious correlation between genotype and phenotype. But this hasn't been looked at that extensively. Our patient falls here in the IBD-like phenotype, and he had a mutation in the BR3 domain. And some of these patients, even with significant truncations, do still express some protein, so that brings a few more questions into the genotype-phenotype relationship. Given that this patient responded to TNF-alpha, the question comes up, why would these patients be responsive to TNF-alpha inhibition? And there is one other patient who is out of the Japanese group that had only IBD-type disease, and he was treated with infliximab. And at the time of publication last year, the patient had not been transplanted and seemed to be doing quite well. So there is some other evidence that TNF-alpha inhibition will work for these patients, at least without HLH. Looking mechanistically about the relationship between XIAP and TNF-alpha, it's known and been well published that NOD2 signaling is important in TNF-alpha production, and XIAP does interact with NOD2 at 2 different domains. One is the BER2 domain and also at the ring domain, so there's a couple of possible ways where XIAP deficiencies could be affecting the NOD2 pathway and leading to aberrations in TNF production. And we had looked at this patient's TNF-alpha levels, and they were quite elevated. Additionally, SHIP1 interacts with XIAP and inhibits the NOD2 pathway, so you can imagine that if you had a defect in XIAP, your SHIP1-mediated signaling through NOD2 would be increased. And again, you'd have increase in TNF-alpha. So to summarize this patient, it was a case of XIAP deficiency who presented with IBD-predominant symptoms and failure to thrive. And he had this interesting B and NK cell depletion, but normal antibody levels. And now thinking about it in retrospect, if you have a defect that involves your inhibitor of apoptosis, one could hypothesize that he was actually making the B cells and NK cells, and they were able to produce antibodies, but then were apoptosing as they made their way into the periphery. And the patient had a good clinical response to TNF alpha inhibition. At the time I submitted these slides, the patient was having a little bit of a flare of disease with increased diarrhea. He was treated with steroids since then, and things seem to be calmed down a little bit more. However, they're back in Puerto Rico right now, but we're looking for a donor and planning to eventually do HSCT. And of note, patients who have XIAP without fulminant HLH tend to do quite well with the right conditioning regimen. So we're hoping for him that this will work. So I'd like to thank Dr. Notarangelo and Dr. Rashid, who have been helping to guide me to take care of this patient, and open up for any questions or comments.
Well, that's a great case. Can you just comment on what his marrow looked like in terms of the flow cytometry there, and what was the distribution? You had no B and no NK in the periphery. What did you see in the marrow?
In the marrow, there seemed to be normal B cell precursors and plasma cells. So it didn't look like his marrow was deficient in B cell development. I don't know the answer to that question.
I'm struck by the fetal hydrops, the cytopenias, the hepatitis, the inclusion bodies, and the worsening of his overall health as he lost maternal antibodies. Putting that all together, could this have been a parvovirus infection in an immunocompromised individual who was B19 searched?
Yeah, and that's a good question. When he was at his hospital in Puerto Rico, they did look for parvovirus, and it wasn't present.
And they looked by antibody and or DNA?
I'm not sure I'm going to remember accurately off the top of my head, but I believe that they did antibody. I'm not sure if they did DNA.
Because if he's immunocompromised, he may not have made antibody.
Right, right. That's a good point. Okay. Well, thank you.